Good evening, ladies and gentlemen. I am Dr Saurabh Misra. I am working as a consultant surgical gastroenterologist and bariatric surgeon at Apollo Hospital at Bannerghatta Road, Bangalore. I welcome you on behalf of Apollo to a brief CME on a topic which is not so well discussed in the past few days, and that is how to safely perform surgeries during the present COVID pandemic. In the end of, you can ask me questions at the end of the seminar, or you can also ping me. You can put it on the box provided. We'll be able to, the chat box which is provided to us, and I'll be able to answer your questions. So going back to the topic, why it is relevant is because we have seen that in the past 2 decades, we have had 3 COVID pandemics in a brief period. So this type of pandemic situations are going to be there for a very, very long time. So we have to be prepared for all this. COVID-19 itself is going to be there with us for a long time, and we have to deal with it on a day-to-day basis. Presently, the COVID-19 is quite a dreaded disease, as the disease profile which states that about 15% of these patients would react very severely to the disease. About 5% of them will become critically ill, requiring admissions. So, on a brief estimate, if we can understand that about in a 7 billion population, even half of the population gets infected, we are going to see about 600 million patients who are going to be admitted to the hospitals. So, what it means to us as surgeons, it means that a whole lot of these beds are going to be occupied by the COVID patients, leaving very less beds and very little resources for surgical patients. So it's a difficult time, and we have been able to formulate certain guidelines to mitigate this. So going to a brief history of COVID pandemic in India. India went into a lockdown much earlier than the other countries. The count at that time was about 500 cases all over India, and there were about fewer than 10 deaths at that time. At this point of time, India stands about 2 million cases, and we have about 40,000 deaths. So surgery is going to be there. We are going to find patients that need surgery. Either they are going to be emergency surgeries, or are they going to be elective surgeries. Now, it was very simple to start with. Before the COVID times, we could easily find out this was the patient who required surgery, and immediately, and this would be the patient who can wait and could have an elective procedure. So during this pandemic, a new form of nomenclature came into being, that is the COVID classification of surgeries. So in this, the emergency surgeries were divided into a surgeries which need immediate care within 1 hour, which means that we would not be able to find out if the patient was COVID positive or not. The second kind of emergencies are those which required surgery within 4 hours. The earlier type of surgeries would be like life-saving and limb-saving surgeries, where we don't have time to react. So I'm going to tell you about this at a later stage, how this classification works. Going to the elective procedures, which is a more of a problematic situation, is because as a surgeon, we do not know that these surgeries can be taken safely in these times or not. So again, the classification of elective surgeries were further divided into urgent elective surgeries, which would require surgery in about a couple of weeks, and this would be like the surgeries which are cancer surgeries would actually become inoperable in the next few weeks, or gynecological surgeries like the cesarean sections, or or the other cholecystectomies, which would actually become like biopsies. Then there were the elective essential surgeries, which you can wait for about 1 to 3 months, where the patient has come into the emergency and has acute cholecystitis. We have managed them conservatively with antibiotics, and these patients could be later taken out for surgery, and in about this time. Then a certain amount of surgeries would be totally elective discretionary surgeries. These are basically the cosmetic procedures which can wait till the time the pandemic in India goes to a plateau or it comes down significantly. Now, as a senior clinician, my responsibility is multifold. It's not only towards my patients, but it's also towards my colleagues. It's also towards the healthcare workers which are working with me, and my family, so that I don't carry the infection home and infect them. For that, I need to be taking care of myself. So first, I take my care of myself, my colleagues, my patients, and then families. They are all linked to each other. So when we talk about doing surgeries, in April, we found in much of February and March and April, we found that a lot of surgeons were becoming sick. A lot of data was coming from China, a lot of data was coming from Italy, which are the epicenters in the first stage. And we found that a lot of surgeons became very sick, and a few of them succumbed. It was a very sad situation. Everyone went on a knee-jerk reaction, and then CDC came into the picture in the US, and they said, which we also followed. They said that elective surgeries should be stopped. Now, elective surgeries, when they stopped the elective surgery, there were a lot of pending cases which were going worse. No one knew what exactly elective surgeries were. So, on a knee-jerk reaction, we stopped all patients, all surgeries coming to our outpatient department. But that would mean a huge amount of patients would get sicker because of lack of surgeries. So what happened was, it was redefined. This surgery was redefined, and then the classification which I have discussed before came into the picture. So any surgeries which require surgical procedures within 2 weeks or 3 weeks had to be done, and those surgeries which could be deferred for about 1 or 2 months, again would be done in due course. So we understood that the surgeons were getting sick because there was little understanding of the disease process itself. There were lack of adequate PPE. There were lack of engineering within the OT complex, which the surgeons could not understand, which were making them sick. And then there were lack of pathways to segregate these patients, and these people are working in the hospital environment, which did not give them chance enough to prepare themselves. In those scenarios, I think India was placed much better, because between the times of March and April, we got enough time to manage ourselves, prepare for ourselves and understand the disease, what it is like. So how does the virus spread? The virus spreads through droplets, which is about 5 to 10 microns. A lot of these droplets would become aerosols, which are smaller, and then these aerosols and the droplets would settle down on the doorknobs and the other furniture, and these items would become fomites. So anyone who would come in contact with these and then touch their mouth or face would get infected. We also understood that there are certain surgeries and processes and procedures which had a lot of aerosols generating, like ENT procedures, intubations, nebulizations, and bronchoscopy, endoscopic procedures. And from our perspective, it was the insufflation, desufflation of the abdomen, which was causing a huge amount of aerosol generation, which could potentially cause the surgeons to become infected and succumb. So having understood this, we had to make processes so that our surgeons and our patients are safe. They get the surgery done like before and go home safely without getting infected. The reason I'm telling is because in Wuhan, our experience was that about 40% of the surgical patients got infected within the hospital. And this is because of the fact that these patients were not segregated from the COVID patients. They got infected within the hospital stay. The result of this was multifold. The mortality rate in surgical patients were higher than the other people. So we found that the mortality rate in these post-operative patients was at the tune of about 27%, while in general population was about 3 to 4%. So these processes had to be developed so that the patients are safe, the surgeons are safe, and we are working in a very healthy and safe environment. For that reason, a COVID task force was developed here. So we developed it it was multifactorial, and we had to advise the management at multiple levels. One of the things that we had to do was to advise the management in terms of engineering and changes in the infrastructure, which would help the segregation of COVID and non-COVID patients, so that the surgical patients do not get intermingled with them, and then they don't get infected pre-operatively or post-operatively. So there was, in these terms, we had to manage the risk factors, the risk to the healthcare workers and to the patients. So when we talk of healthcare workers, we needed our nurses, our technicians, our associates to be safe, and for them we had to sensitize them of what exactly the disease is. So we had to again, the segregation was proper. We had to provide them with adequate and proper PPE, and there was this safe operation theater environment we had to ask them to work in, so that they feel safe about it. The most of the hospital our hospital theaters had an exchange rates of more than 40 cycles per hour, and that would mean that the exposure time was very minimal if there was an aerosol which happened. So from the start, when the patient would come into the hospital, it was important that the patient was recognized as having COVID or not. That became very important because about 80% of these patients were asymptomatic. So the risk, to start with, we had started what is known as risk stratification score, being developed by one of our infectious disease consultant, Dr. Vinay. Obviously, it became irrelevant because the patient load became too much, to stratify everyone. And so we started treating every patient as COVID times. So we developed processes in accordance with the guidelines provided by the sages, which said that every patient should undergo RT-PCR before undergoing surgery. So these, but we understood that the RT-PCR was not 100%. Only it would pick up about 70% of the patient, 30% would still be not known, and they could be asymptomatic. So we had to take precautions either way. But at least about 70% of the patients we would know that they are negative. So those patients who were negative, and those patients would be taken up for surgery next day. And in case the patients actually came in emergency and we had very little time to work on it, there was another system called a gene experts, where we got the result faster in about 4 hours, and we could manage to find out the patient. This also was about 70% foolproof, but it had still about 30% of false negative rates. So now these patients who tested COVID positive were then moved to the COVID designated areas. For that, the structural changes were there, so that the elevators as well as the areas where the COVID positive patients would come would be totally segregated from the rest of the patients. Most of these patients, if they come, they were asymptomatic and came positive, we would not operate on them. We would wait for some time, and then these patients were managed conservatively and discharged when they became stable, and asked them to come back for surgery after about 2 weeks with a COVID report. Now, training of nurses were extremely important, because they would understand what is the importance of hand hygiene, wearing masks all the time, in when they interact patients. Initially, there was a lot of apprehension, but then they realized it was if they took proper precautions, it is going to be okay. So, giving them the confidence that yes, I'm with you and we are in the same boat, give them confidence to go ahead and look after these patients. And then there was the training followed, in which we asked them to demonstrate how to wear, how to don and doff the PPE properly. And then a few of them would became positive, but this was not because of the patient care. It would be because of the community spread. But these all were stable people and came back for work within about 2 to 4 hours. So operation theatre environment is extremely important when you look at patient safety and healthcare safety. So the SOPs were developed within the anesthesia department and the surgical department, so that they understand their jobs. And the air exchanges were ascertained that they were always above 40, so that the minimum aerosol generation time or aerosol clearance time would be in the range of about 10 to 15 minutes. These surgeons who were getting infected in Wuhan and other places were working in an environment which was not very safe. So their exchanges were less than 18 cycles per minute. So that it's because of that the aerosol generation was huge and stayed in the environment for a considerable amount of time, making them sick. So then comes the adequate PPE were given to the nurses, and the surgical specific precautions were taken. If suppose they require regional anesthesia, these people do not require full PPE, because then there is no aerosol generation in any other. Like it's typically like a urology procedure where a stent removal would be done, or a very brief pelvic surgery. So in our practice, there was a lot of debate about open procedures better or laparoscopic procedures better, and this debate went on for some time. For a few people, open procedure was better because that it would be quicker, there would be less generation of aerosol, um, and then but then the other thing was that there were a lot of, when you use the cautery, there were a lot of smoke, and there were a lot of these patients would stay in the hospital for a longer period of time, exposing themselves to a potential infection for a longer period. Now, surgical smoke and surgical aerosol are the two things which are known to have virus in them. It is not done in COVID-19, but it was done in human papilloma virus and the hepatitis B virus, where they would find that it is, but the virus is present in surgical smoke. But the one problem is that we really don't know if the virus was infective or not, because to prove that the virus was viable and infective, we had to culture it, and none of the reports actually told us that these viruses were actually infective. But then we had to take precautions. So much of our work, about 82% of our work, is laparoscopic work. And laparoscopic works very well because the patient has less pain, less comorbidity, and less morbidity, and goes home faster. So that the overall exposure time to the patient to the hospital is less. One problem was that there was aerosol generation during the insufflation of the abdomen with CO2. And over time, it was speculated that when you do a surgery, let's say for an hour or two, the concentration in that CO2 would be very high. So when you desufflate this, the amount of virus which would come out would be extremely high. So to mitigate that, there were various procedures, processes which were put in place, and then one of them was that we had to attach the outlet to a chest tube drain, which was submerged in sodium hypochlorite 1%, and that would potentially deactivate the virus. But then this was in accordance with the SAGES guidelines, and we are continuing to follow this process, and we've been pretty successful in that. The more advanced system is the Buffalo system, which has a filter built into the system, and what it does is it keeps on clearing the environment on a regular basis. So without disruption of the surgical work, this machine constantly monitors the pressure in the abdomen and removes the excess gas. It also can work in open surgeries where it assesses the cautery when it is being started, which when it's working, and sucks up the surgical smoke, reducing the exposure to the healthcare workers and the surgeon. So from the patient perspective, there was the other types of risk that we had to understand. The risk from patient perspective is the intrinsic risk. How it is perhaps the amount of exposure in the community the patient is having of a specific virus. So that would mean that when the virus surge is going on, it is more chances that the patient can get infected. Now, and the individual risk could be that if suppose you have a patient who is about 65 years, having a lot of comorbidities, and is a male patient, Asian, all these are risk factors indicating that this person is likely to get infected more than the others, and he would have a worse disease outcome. Then when we combine the overall risk with the individual risk, we come out with the overall risk. The intrinsic and the individual will give us the overall risk. Now this assessing this risk would tell us that how the patient is likely to get infected within the hospital, or he is asymptomatic patient who is coming to the hospital, and he is within the period where he is likely to have a negative COVID report and may become positive after the surgery when these symptoms starts. The reason is that from the infection to the appearance of symptoms and the test being positive, it takes about 5 to 7 days. The second thing is that we would understand that these are what kind of anesthesia would be appropriate for this patient. Would be a regional anesthesia would be good enough, or a general anesthesia is warranted in the patient. More than that, we decide that if suppose if it's a regional anesthesia, the we don't have to wait for the aerosol clearance time, which is about 10 to 15 minutes. So the patient does not have to have to wait in the OR for recovery. The patient and the clearance, the next patient would come in earlier. Although we had a protocol that in between the patients we would have a time period of about 1 hour at the most, which gives us enough time to clear the environment, and then you have the you have sanitize the whole area for the next patient surgery. So the results, so we implemented all this 360-degree of patient care within the system in Apollo Hospital, and we found that we could safely perform these surgeries, and despite of a initial dip in surgeries in about in April, we were able to perform over 350 surgical procedures in May and June. Understandably, because the surge of the infection took place in 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 July, so that the overall patient load became slightly less for the surgical patients in July. And we were, because of the processes, we were able to pick up the uh, the asymptomatic patients at a lot of time, and we were able to save these patients a surgery which could be deferred and be done later on. Um, very few patients actually developed symptoms. Despite of that, a few, one or two patients that we can remember developed symptoms after the procedure, but they were managed accordingly and they went home. So I would, because we were able to successfully do all these surgeries, it was because of the COVID task force, and especially the personal involvement of the CEO, Mr. Davison, and the ADMS, Dr. Sahana, especially the members of the COVID task force, Dr. Vinay, who is the infectious disease consultant, and Dr. Venkatesh, who is a neuroanesthetist, Dr. Jeshi, who is a senior microbiologist, who are constantly giving us inputs from what is happening inside and how the caseload is increasing on day-to-day basis. We are coming to a point where the caseload in Bangalore is reaching unexpected proportions. So as per yesterday, it was about 1,600 cases reported in Bangalore, and in the previous few days we have seen over 2,000 cases. So we are going to see that these patients are going to continue to grow at a rate. Going by the experience of the other places like Yuan and Italy and New York, we know that what will happen eventually is that this surge will go up and come down eventually. But it is not going to go to zero. The risk of getting infected, the risk of the healthcare personnel, the risk of post-operative patients getting infected is going to be there. So these processes which we have developed in the task force is going to be there with us for a very, very long time. This would give us and our patient a lot of confidence to come to the hospitals and get surgeries done. I am not exaggerating the fact that in April we were not that confident. But at this point of time, I can confidently say that any patient who comes to my outpatient department, we do not refuse. We explain to them the various risk factors involved in this, but we do not refuse them surgery. That has happened because now we understand the disease, we understand how it works, and how we understand how to keep ourselves and healthcare personnel safe. So in conclusion, the elective and emergency surgeries can be safe during the ongoing pandemic without risk of the patient or the healthcare workers. A strong preparation in administrative side, building protocols and modification of infrastructures, admin staff needs to be sensitized. All this is going to be an ongoing procedure, ongoing process. More than that, we have to go back and reevaluate ourselves. What processes we made, were they effective or not? If they were not effective, what better we could do out of it? If they were effective, to continue those processes. The 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 worst part here is that we still need to know a lot about this virus. We do not know. Maybe it's the tip of the iceberg we know at this point of time. So the guidelines and our risk factors, understanding of the risk factors, and our reaction, our response is going to change over time because of the fluid situation we are in. At the end of it, the virus is going to be with us for some time. So let us be prepared. Thank you for the patient listening. Thank you. If you have any questions, please put it on the chat box. I'll be happy to answer. Good evening. Thank you.